This is lesson 4C, alterations in hematological function. So there are two parts of the blood. There is plasma, which is the fluid portion, and the cellular components, which are the formed elements. Erythrocytes are red blood cells. This is just a review from PathoPhys. You should know this, but again, just a little review. Red blood cells transport oxygen from the lungs to the tissues. Then you have leukocytes, which are the white blood cells, which are the mobile units of the body's protective system. And there are multiple forms of white blood cells, as you know. And then you have the thrombocytes, which are platelets. And those are cell fragments that form hemostatic plugs to stop the bleeding. Anemia in general is the reduction in the number of red blood cells, the quantity of the hemoglobin, and the volume of packed red blood cells that are available to below normal levels. So iron deficiency is the most common nutritional deficiency during childhood, and it's also the most common type of anemia. It is a decrease in the total number of circulating red blood cells, a decrease in the concentration of the hemoglobin, or both. Groups that are at risk are children from a lower socioeconomic status, infants that are greater than 6 months of age, toddlers, and adolescents. So why are these groups at risk? So newborns have a store of iron. If the maternal nutritional state was satisfactory, so if the mom did not have a healthy pregnancy, then they probably won't have enough iron to get them from infancy to 6 months, because in about 4 to 6 months of age, iron stores begin to decrease, so that the dietary iron must be added. So again, that also, if you're from a lower socioeconomic status and you don't have the proper formula, or you're cutting formula or not properly feeding your child, then they're not getting enough iron. Cow's milk, interestingly enough, during infancy, can actually lead to anemia because it irritates the gut to consistently lose blood in the gut. It's not necessarily noticeable, but it's small enough that it can induce anemia. And then adolescents, you got to think about girls, they're having their menses, their growth spurts, and then they also may have sporadic dieting, so they may not be getting enough iron. Clinical manifestations. So if they have mild to moderate iron deficiency anemia, they're going to be asymptomatic, okay? These are severe iron deficiency anemia that are going to have signs and symptoms. They're going to have pallor, tachypnea, tachycardia, fatigue. They're going to have poor feeding. They're going to be irritable. They're going to be not interested in play and activities. If you can correct the underlying management in iron deficiency anemia, that would be your goal. The most common medication is obviously iron, because you're going to be replacing that iron to decrease this anemia. It is page 592. I corrected it from the slides on Blackboard. The main complaint with iron is GI. You're going to have constipation and GI discomfort. You want to try to give it on an empty stomach if they can tolerate it, because they'll have the highest absorption rate. If not, you can give it with or following meals, but they're not going to absorb quite as well. If they're young enough that it's liquid, you want to mix it with juice or water and give it through a straw. You want to encourage foods high in vitamin C, because it actually increases the absorption of iron. And so when I was working in maternity, we would have a lot of women that would have anemia in their second trimester. And so we actually recommended that they take iron with a glass of orange juice, because it has vitamin C in it, and then it also increases, like I said, it increases the amount of iron to its maximum level. And then you can also have dietary management, so increase intake in high iron foods, liver, lean meats, legumes, dried fruits, green leafy vegetables, whole grain or fortified cereals, pastas, and breads. In case you can't tell, those are pretty, they are healthier and more expensive foods, which is also another reason that some people don't get as much iron as they need. So moving on to a different type of anemia, we've got aplastic anemia. This is where the bone marrow is not producing the adequate type of blood cells, and about 80% of aplastic anemia are acquired. You're not actually born with it. So aplastic pancytopenia is a reduction in all of the cellular components. And then, like I said, the bone marrow is not producing the types of cells that you need. So known causative agents, chemicals or benzene, drugs or chloramphenicol, or actually NSAIDs as well. Viruses such as hepatitis, insecticides, pesticides, radiation, lead, model airplane glue, interestingly enough. So you want to get a good history when you're interviewing the parents. Clinical manifestations include tachycardia, fatigue and weakness, pallor, fever, infections, bleeding, bruising, petechiae. Diagnosis, like I said, you want to get a history, and when all of their signs and symptoms started, you're going to want to get a complete blood count with diff and a bone marrow biopsy, and the result of the bone marrow biopsy, if they have aplastic anemia, is it's going to be yellow fatty bone marrow instead of the red bone marrow that you would want to see. Medical management is treat the underlying disorder. Obviously get rid of those toxins if you can. You're going to get blood transfusions, potentially all three. And the granulocyte colony stimulating factor, it stimulates the bone marrow to produce healthy cells. And so your body will produce more and more healthy cells. You also might give immunosuppressive agents like cyclosporin, and bone marrow transplantation is the treatment of choice. You want to support the family in this because this disease can be fatal. It's not going to go away, and so you definitely want to support the family and provide them with resources if needed. Sickle cell anemia is another one you want to provide a lot of support. This is a lifelong, very sad illness. So this is a chronic disease resulting from a hemoglobin defect. It is autosomal recessive disorder, so both parents must be carriers of the gene to be affected. And if both parents are the carriers of the gene, there is a 25% risk for, since it's a recessive, there's a 25% risk for their child to get it if you draw those, that gene block square thing. So your fetal hemoglobin disappears at about 4 to 6 months of age, which is about when the sickling begins and then some signs and symptoms of sickle cell begin for these children. Most organ systems are affected by infarctions at some point throughout the child's life or adult's life. They're going to have delayed puberty, and growth is common in sickle cell children. These next three we're going to go over in detail over the next couple slides, but I do want to mention a couple things. Bacterial infections are the leading cause of death in young children with sickle cell because they are at such high risk of getting infections. And the splenic sequestration crisis is when blood is trapped in the spleen, and most undergo a splenectomy by early childhood, which also leads to decreased immunity, which can also increases risk of bacterial infections. So just good hygiene and good home practices are important for this population. A vaso-occlusive crisis is the most common, and this is basically a blockage of the blood vessels. So stasis of the blood with clumping of the cells and microcirculation, which can lead to ischemia and infarction because that blood vessel is blocked. Their red blood cells are sickle-shaped, And so secondary to that, they're going to have low oxygen concentration, they're going to have acidosis, and they're going to be severely dehydrated. And the blood has difficulty flowing through small blood vessels because of the shape. The sickle cells also tend to clump together, which causes the occlusion, which can lead to tissue ischemia, infarcts, and organ damage. Most seriously affected is the spleen, and it doesn't function. So a normal spleen doesn't function properly. If they have sickle cell, the spleen typically does not function properly by the time they are 6 years old. We had already talked about the splenic crisis. And so even if they have a spleen, it's not going to be functioning properly. So they're still going to be immunocompromised. Most of them don't have their spleen. Their liver is also affected. So they're going to have hepatomegaly or cirrhosis. And their brain is also affected. So they may have a stroke. A lifespan of a sickled red blood cell is only 12 days. A normal red blood cell is 120 days, so 10 times that. So think about their oxygen levels and everything else that not having the amount of red blood cells they should entails. Triggers to the sickling of the red blood cells include infection, fever, dehydration. So hydration at home is very important. A lot of kids, if they're playing sports or it's summer and they're outside running, become dehydrated and then they can go right into a crisis. So good hydration is important at home. Hypoxia, high altitude. So if they're traveling or hiking, you want to address that. Vigorous exercise, like I talked about, can lead to dehydration, but it can also cause stress on your body, and so it can cause those cells to sickle. Emotional stress is also a trigger, as well as surgery, and then cold temperatures can also be a trigger. Vaso-occlusive crisis is a painful crisis, and we're going to go over these next couple things. But I just want to talk about nursing management of all of these. It focuses on pain control, hydration, oxygenation, and infection prevention. So when you're talking about sickle cell patients, you want to focus on all of those. So a painful crisis is the most common. Pain can occur anywhere, but the most common sites are bone and joint pain. So the spine, the knee, the shoulder or elbow, or the femur regions. The pain may come and go. They may have a mild crisis that can last a few hours, and you can just give them some Tylenol at home and that'll help them. But if it is a severe crisis, it may last for days or weeks, and they'll need to come into the hospital for IV pain medicine, a PCA pump, hydration, all of that, maybe transfusions. Acute chest syndrome is very severe and life-threatening. It's often confused with pneumonia, but the underlying cause is an infection, and you're also going to have a pulmonary infarction from those sickled cells or a fat emboli. Symptoms include chest pain, pain in extremities, a fever, a cough, or respiratory distress, which is probably the number one difference between acute chest and just a regular pain syndrome. I'm going to tell you, if they have sickle cell and they come in complaining of pain, you're going to get a chest x-ray right away to see if they have acute chest. If they are in severe respiratory distress, they probably have acute chest anyways. A lot of them have compensatory mechanisms in their respiratory status so that they, even if they are sickling, they may be a little low on oxygen, but they're not retracting, they're not flaring, they're not complaining of this severe chest pain like they typically do with acute chest. Like I said, it is an emergency. Sometimes it results in them getting intubated. And if they get it once, they are more at risk for getting it again. Hand and foot syndrome typically occurs in ages 6 to 4 years of age. It's basically bone marrow ischemia of the hands and feet. It's an unknown cause. Could be stress or it could be cold induced. The symptoms are swelling of the hands and feet, and it's going to be painful. Interestingly enough, the extremities are actually going to be warm, and they're going to be extremely tender, so pain management is important. A cerebrovascular accident. 50% of sickle cell patients will have a stroke if they're not properly managed, outpatient and inpatient, and some of them are going to have a stroke regardless. Symptoms include change in neurostatus, vomiting, vision changes, and ataxic gait. If they, or symptoms continued on include spasm of extremities, they might have seizures, they may have extremity numbness, slurred speech, they may have an unrelenting headache. If they do have an unrelenting headache, sometimes headaches are just their normal pain sites, but if it won't go away with pain medicine, you may want to check their blood pressure, see what's going on, and then maybe page the doctor if it's high, or if they're also having neuro symptoms that you would be concerned with them having a CVA. Priapism is also a problem in sickle cell patients. Basically, the penile veins are being obstructed, and it causes persistent, painful penile erections. Onset is in early childhood or in adolescenthood. It can be recurrent, or they can have severe episodes which can result in impotence. You want to encourage the child to avoid smoking, alcohol use, and illicit drug use. Medical management for it, you want to have bed rest, you're going to have warm sitz baths, IV hydration, and pain management. Medical management of sickle cell disease as a whole, you're going to give fluids, because those fluids reduce the viscosity of blood. So their blood's gonna travel easier, and you're gonna reduce the likelihood of an occlusive crisis. And so you also wanna do pain management. You're either gonna do IV or oral meds, you're gonna have narcotics and analgesics. You're gonna wanna give them oxygen. A lot of time the oxygen provides comfort to them, or sometimes they do drop their saturations depending on how bad they're sickling. You want to give antibiotics if they are having acute chest syndrome. You want to provide comfort measures, so position, warm compresses to affected areas that you do not need an order for. You also want to identify triggers to the crisis so that the parents can avoid the triggers at home. They're probably going to be on folic acid prophylactically. They're also probably going to be on penicillin prophylactically, and they're going to be on hydroxyurea, which increases the hemoglobin concentration. Those three meds are kind of the standard at VCU of what their sickle cell patients get outpatient. So folic acid, penicillin, hydroxyurea. Splenic sequestration crisis, we've talked about this a little bit already, but I'll talk about it a little bit more. It occurs 6 months to 3 years of age. They're at risk. By 4 years of age, like I said earlier, most have had an infarction. The blood pools within the spleen, so the spleen enlarges, the hemoglobin drops, so they are at risk for shock. And it can be potentially fatal. It can cause death even within hours of the onset, which is why most of them do not have their spleen. Clinical manifestations, of splenic sequestration crisis is sudden pallor, irritability, tachycardia, faintness, rapid breathing, and an acute increased abdomen, hypovolemic shock. Most of the sickle cell parents are really good at noticing sudden changes, and so hopefully they will get the child to the hospital ASAP. You're going to replace that blood volume. You're going to treat the infection if it's present, and you're probably going to do a splenectomy in order to hopefully make it not fatal. Aplastic crisis is a decrease in erythropoiesis, which is temporary cessation of the bone marrow, which equals red blood cells production is stopped. So red blood cells are no longer being produced. Causes are the parvovirus and then the depletion of folic acid. It usually lasts about 5 to 10 days. The hematocrit drops 10 to 15% per day. Sickled red blood cells or shortened lifespan leads to a heightened production in bone marrow as is, and then you're going to have a decreased production of red blood cells. Clinical manifestations of this include pallor, lethargy, headache, fainting, or you want to ask if they've had a history of a URI. Again, a mild crisis, you're not going to treat it. It's very self-limiting, 5 to 10 days. If they do have a severe crisis, you're going to want them to come in, and you may do a red blood cell transfusion, and they're probably going to get fluids and pain medicine. Moving on to another illness or disease, hemophilia. It is the most common congenital bleeding disorder, and it's defined as a deficiency in specific clotting factors. Hemophilia A is factor VIII deficiency, and it is the most common and is actually 85% of hemophilia cases. And then there's hemophilia B, which is factor IX deficiency. It is an interesting disease. Again, it has to do with genes. It's an X-linked recessive disorder, and males are solely affected. So if the mom is the carrier of the trait or gene and the dad is unaffected or the non-carrier, there is a 50% chance that they will have a male with the disease and a 0% chance that they will have a female with the disease. I have a friend that I used to work with at the health department who had 2 sons, and both of them had hemophilia, and none of the women in her family had hemophilia. So, interestingly enough, the first sign may be prolonged bleeding after circumcision, and so if that baby is bleeding for an abnormally long time, they may go ahead, if they don't already know that the child has it, go ahead and draw some blood. It results in prolonged coagulation up to 2 hours or more. The child will have a tendency to bleed into the joints, which is the definition of bleeding into joints is hemarthrosis. It can be mild to severe. They can also bleed into the muscles or body cavities. Clinical manifestations, like I said, they're going to bleed into the joints, so knees, elbows, ankles, hips, shoulders. With the progressive bleeding, the joint becomes hot, swollen, and immobile, and they're going to have pain, tenderness, and swelling, and contractures. So you're going to want to immobilize that joint. It's already immobilized itself, but you want to further immobilize it so they don't further injure it. They also may have nosebleeds. They may have blood in their urine, so they may dip their urine at home. They may have a hemorrhage in their central nervous system, which is a major cause of death, so a stroke. Medical management, they're going to get transfusions. They're going to get factor replacement. There have been previous complications of factor that have been contaminated with viruses. New technology and testing has gotten better with that. So factor, they're going to get factor VIII at home, and it may be prophylactic, which decreases bleeding episodes. I know my friend had a ton of factor at her house. Factor is very expensive, and like I said, they may be on it prophylactically if they, like she has 2 teenage boys who are very active, and so it's going to prevent bleeding episodes. Desmopressin, DDAVP, can also be given only to hemophilia A. It stimulates factor VIII that is stored in the blood levels and increases the percent of the available factor, I think by 3-fold. Yeah. So nursing management, you want to prevent injury, you want to encourage non-contact sports, you want to create a safe environment in their home. Think about those infants and toddlers crawling around and how many times they hit their knees, and if they have hemophilia A, it's just going to further complicate things. Be sure they wear helmets and pads. Avoid aspirin or aspirin-containing products because that can increase bleeding. Want to shave with an electric razor because that can decrease bleeding. You want to apply pressure to superficial cuts or abrasions. This can be for a longer time than you normally would, like 15 minutes. You want to wrap and elevate the extremity or whichever injured part they have injured themselves, and provide ice. Range of motion is only a preventative way, that's so that they maintain function of their joints properly. And then you may want to give factor before dental visits because of the bleeding possibility at the dentist. All right, so the last one is immune thrombocytopenic purpura, which is ITP. This is an acquired hemorrhagic disease. It is an excessive destruction of platelets in your spleen. The rate of destruction exceeds the rate of platelet production, so your blood clotting slows and your platelet count decreases. Typically it prevents with discoloration caused by petechiae beneath the skin. It occurs in children 1 to 10 years of age. It almost always follows a viral infection, which is why it's acquired. And so you want to get a good history from them, and it is an autoimmune disorder. So about 1 to 4 weeks after that viral infection, they may just have a URI. They're going to have ecchymosis and a general petechiae rash. They may have spontaneous bleeding of the skin. They may have hemorrhagic blisters in their mouth and their throat, which can be painful, and asymmetrical bleeding on the legs and the trunk. They may also have GI bleeding, so blood in their stool. They may have blood in their urine. They may have nose bleeding. They may have an intracranial hemorrhage, which is the most severe, but is, thank goodness, pretty rare. You're going to diagnose it. You're going to get a good medical history and presentation. You're going to ask about recent medications that they've been on, and then any recent illnesses, especially viral. You're going to do a CBC, including a platelet count, and you may do a bone marrow aspiration. Medical management is really supportive care. We would send these children home a lot because there's not a whole lot that we can do for them except to support them to decrease their activity. You want to restrict it to make sure that they don't bleed even more. You may give corticosteroids. That reduces the rate of platelet destruction. It also reduces bleeding. You may give IV immunoglobulin, which increases the platelet count. Again, these are in severe cases, not in mild to moderate cases. So about 20% of people with ITP will develop chronic ITP. And basically the only difference is that chronic ITP, you've had the symptoms for 12 months or more. This is when you want to think about doing platelet transfusion, and you may even do a splenectomy. Nursing management, you want to avoid aspirin or aspirin products. You're not going to do rectal temperatures. You're going to limit contact sports. Basically use a soft bristle toothbrush. You're going to decrease those bleeding. Anything that might lead to bleeding, maintain a safe environment. And then nursing management, we talked about how a splenectomy may be an option for chronic ITP. You want to be sure they get the pneumococcus vaccine, and they may be on daily penicillin, these doses, or if they're allergic to penicillin, they may be on erythromycin, just because their immune system is now going to be decreased and they're not going to be able to fight those infections like they used to be able to. So that is all. Let me know if you have any questions.